Dr.
Thank you.
Jitendra.
Thank you, Ravi. Uh, Thank you so much for the invite. I would be speaking mainly on the myopia control glasses. And I would start with the key factors beyond genetics, as Dr. Siddharth has already said, and the key things about phenotypic expression of the genes depends on the environmental factors and depending on the SNPs that he has nicely elaborated. So the key factors are peripheral hyperopic defocus, which we have learnt since last 15-20 years. Altered dopamine release depends on the outdoor sitting and UV light stimulating dopamine release. And then there has been another factor, which is high contrast stimulating bipolar cells, depending on whether the central cone is being stimulated or the peripheral cones. Between the two cones, the central cone is being stimulated or not. We will take these theories as the type of glasses come. So this is now almost into theory that it is the parafoveal area, the sweet spot. There was a recent publication which shared that it is only the 8 to 10 degree of parafoveal place which needs optical defocus to prevent the progression of myopia. And these papers are mainly from Earl Smith 3. The conclusion was published in 2010, where he showed that optically imposed defocus. So the beginning of some of the articles were on infant macaque monkeys, where they lasered the parafoveal area, and they found that axial growth was still possible despite axial growth was stopped because of this parafoveal lasered part, and not because the fovea was still intact, and yet the growth was stopped. So he showed that optically imposed defocus can also alter the shape and pattern of the peripheral refraction in infant primates. This is purely experimental studies. And so how do these glasses actually work? So these glasses, basically what they do is that instead of the relative peripheral hyperopic defocus, which is already there in the eyes of progressing myopes. Now, there are studies which show that it is not the case in all the progressing myopes. But what they do is they create a peripheral myopic defocus. Instead of the peripheral hyperopic defocus, the peripheral part of the lens is made in such a way that it creates a peripheral myopic defocus. And these are some of the lenses, no financial interest, but these are some of the lenses which are available. DIMS is defocus incorporated multiple segments. In all these lenses, the central 9 millimeter is the clear zone, and then there are peripheral lenslets. Depending on the company, they are either in honeycomb shape or in concentric rings, or the posterior surface has these rings. So these are different ways, but the endpoint is same, that they are creating peripheral defocus. Now, where does the good old peripheral add-on lens do? Right now, we are using it mainly when we are using higher concentration of atropine and when patient is complaining. As Dr. Mihir showed you, that some of the patients do complain. In his work, almost 25%. In our work, almost 10% of patients, when we increase the concentration of atropine to 0.05%, they do complain of blurring in near vision. And there, this can be added. Do they work alone? Not much clinical evidence that they do work alone. Well, there is a lot of clinical evidence that the peripheral defocus lenses actually work, and now we have got almost 6-year results of DIMS. Similarly, there have been articles where they have compared the two major lens companies, and there's a wonderful article on optical characterization of these two lenses. So they have done some MTF morphological studies. They have passed the line. Good read. Just tells you more about the lenses. They function equally well. And this is the head-on comparison some of the studies have done. In short, both the lenses work equally well. And our experience, we have used all the three lenses that are currently available in the market. We feel all three of them, they work nicely in all the patients. So there is no one short thing that this would work better than another one. This is something new kid on the block, has not been released in Indian market, but this is what I was talking about, that when both the central and the surround cones are covered by uniform illumination, there is no contrast response. And then when there is more light on the central cone, then the average on the surrounding cones, the bipolar cells are activated. And then similarly, when it is other way around, there is an off response by the bipolar cells. So what it is doing is, instead of 9 millimeter, there is a central 5 millimeter clear zone, and artificial contrast activity is there. Visual acuity is better even after these dots are there. So these lenses do produce good quality visual acuity. They do reduce the contrast slightly, but it is uniform. And there have been good results outside India. We do not have any experience of these lenses. They are not yet available in the country. So in conclusion, I would say that glasses are effective in controlling the progression of myopia. They can be used as first line, and it will be a good add-on in treatment protocol to atropine, which we have been doing because bulk of our patients, when these lenses were introduced 4 or 5 years back, bulk of our patients were already on atropine, and we already had non-responders, and we were wondering what to do only by increasing the frequency or concentration. And then the lenses came. So bulk of our work is as a good add-on therapy to existing atropine patients who are not responding. So thank you so much for the invite again. Thank you.
Thank you, sir.